any day, if Elyssa send me a case, I will be like, I can sleep well at night. It's like,
Hey, why? I send you cannot sleep well, man.
easy. Hi everyone. So welcome to another episode of the By Angle podcast. Over here today we have Dr. Darrell and Dr. Elyssa, who's our endodontist here as well. Today we're going to talk about the very long old debate about implants versus root canal treatment. And that's even for dental students. When I was studying, it was like there was a whole actually a series of lectures dedicated to just implants versus root canal treatment, whether we should save the teeth or whether should we remove the teeth and place an implant or not. So I think a lot of people have a lot of misconceptions regarding dental implants, right? Because it's like, what are dental implants? So Darrell, can you let me know what are dental implants about?
Well, I was trying to think of something corny to say, but anyway. Dental implant, essentially it's just, you think of it as a little titanium post that's stuck in your jawbone. How little? On average, about 4 millimeters in diameter, right? So millimeters, not meters. And then that titanium post holds the tooth. So that tooth, we make it and we shape it such that it looks and feels almost like your own natural tooth. I used to tell my patients, it feels, it looks, it smells like your own natural tooth, right? So right now, as of today, I mean, that's the most natural thing that we have for a replacement of a tooth. But of course, I mean, well, as you mentioned earlier, implants are not the be all end all. I think since the early 2000s, there have been multiple studies that have been comparing, survival rates of root canals and implants. So the debate has been,
Like
I think
always,
it's still
right?
going. It's still
going,
ongoing
right?
today, yeah.
It's like the root canal guys don't really like to be friends with those implant guys in the conferences. But I think there's more consensus that's saying that, like, we until the end of like when you really have no choice, then you remove the tooth. That's our philosophy, at least, I think. So with regards to an implant, what material is it, and like why are there so many different types of brands out there?
Okay, so implants basically they are type 4 titanium, in material. All right. Of course, there are slight variations here and there. Some people add in a little bit more different kinds of metals inside to make it a stronger alloy. So you have sometimes some companies produce type 5, so they are a little bit stronger than type 4. But by and large, the main ingredient is still titanium because titanium is what's compatible with the human body. Of course, nowadays in the market as well, there are alternatives such as zirconia implants. So I think what you would see it being marketed as is a ceramic implant. I mean, technically speaking, it's not really a ceramic per se. It's still a metal, just that the whole thing looks white. But inherently, zirconia is still weaker than titanium. So at our clinic, I mean, we use titanium implants. Yeah. So zirconia implants is not that we don't offer it. We do, but very, very selected kind of cases, I would say.
Yeah. Okay. And why are we not doing more? Because it mostly breaks, I think. That's a worry, right, I guess.
Yeah. So zirconia, I mean, people mostly choose it either because very, very, very small subset of the population on Earth have a titanium allergy, right? So titanium implants are not suitable for them. Some people like because of our metal-free environment, metal-free philosophy. And there's nothing wrong with that as well. It's just that to date, right, zirconia itself is still, the flexural strength of zirconia is not as strong as titanium. So if you were to use it for somewhere in the back of the mouth, it's not exactly the most reassuring thing to do.
Yeah.
Yeah.
Okay. So, I mean, when we thinking about implants versus root canal, at what point of time are we thinking about this topic for a patient point of view? So what is a root canal exactly, Elyssa? I think we've also covered that a lot before, but I think for viewers there, I think people might want to know what's a root canal treatment.
Okay, so we have to start with talking about the tooth first.
Yeah.
The tooth, you have many layers. The outer layer is enamel, the second layer is dentin, and right in the center there's an empty space where we have the blood vessels and nerves, which is what we call the pulp. So sometimes the pulp can be infected due to many reasons, and the top 3 reasons are usually deep dental decay. Second one is a cracked tooth, and the third one might be dental trauma. So when the pulp is infected, there's pain, there's discomfort, or sometimes it can just be a very silent infection, and that's when we need to do root canal treatment. It starts by actually drilling a very tiny hole in the tooth, as small as possible, to access all the root canals. And the first stage will be to actually do cleaning and shaping. In layman's terms, it's actually called disinfection, getting rid of the bacteria, placing some medication inside, and then the second stage is actually filling it up. So in other words, root canal treatment is very simple. It's just the patient just feels like they're going to the dentist to get a filling done, but it takes a little longer duration. Then we just mummify the tooth, and the tooth can still function and look as per normal. So actually, root canal treatment, I don't know why people are so scared of it. It's actually very simple.
I think most people are scared of it because of pain, right? Isn't it like the
I know
number
it, I
one
know it.
thing, right? They say, oh, you're going to remove my nerve. That sounds like super scary.
Okay, so this is just Darrell's personal observation. After more than 10 years of practice and everything, right? I think, right, a lot of people when they need a root canal, right, it's because the nerve is inflamed, so they're in pain, right? So when they come into the dentist, they're already in pain, and we all know a hot nerve or hot tooth, extremely difficult to get profound anesthesia, to profoundly get it numb, right? So and the patient needs a root canal, but the dentist cannot get it really 100% numb. So throughout the process, they do still feel a little bit of discomfort. So therein, everybody kind of relates, oh, root canal means, wow, a lot of pain. But, if you don't wait to that point, all this won't happen. So actually, root canal it's not painful.
And actually, the patients who actually Google and check out what root canal is, when they see all the equipment, all the fine equipment, they're like, oh, this looks really scary. They look like little needles. But actually, they're just tiny brushes. To put it simply, they're just tiny brushes to do a cleaning. It's not so scary. And we are not, there's a little bit of discomfort if, let's say, you're already in such severe pain. But by and large, they feel so much better. It's meant to relieve their toothache.
Yeah. That's, I don't know, yeah, but we get really, maybe it's like the fear. Everybody's like, some dude somewhere out there that's just causing a lot of pain on root canals. That's called spreading the rumors around.
The root canal, you'll be like telling everyone about it. But if you had a good root canal done, you're like, okay, life has continued.
Yeah, true. So the bad reviews
doesn't go around
spread
and say
more.
like, oh,
Yeah.
root canal was done well, I'm not having any pain. People don't usually say that because they just carry on with their lives. As per normal, right?
Yeah, in fact, I think our patients, my patients, right, I think not very often you get a lot of pain from it. Yeah.
Most of mine, right, I'm a little bit more yasu. I'll be like, okay, after this you might get some pain, take the painkillers, take it as standby. And I recommend maybe you can take for the first 1 to 3 days depending on how you
Yeah.
feel. And then when they come back for the second visit, most of them are like, I didn't even take the painkillers.
Yeah. But I think there was a study that said that if you try to give them a very high expectation that there's going to be pain or there's like a lot of please take medication, everything, actually their pain threshold gets higher and they feel less pain.
So under promise over.
So what I'm saying is right.
That's what that's what I learned before lah. So so it's quite interesting. But how do we get them? How do we know that they need to do a root canal? How do they come to a conclusion that they have to think about implants versus root canal? I think that's the question that I think I have a conversation with my patient every other day about this implants versus root canal treatment, right? And at what point of time does a patient have to face that kind of judgment? Is it because the tooth is really broken down, I would say, or like?
Okay, I think it starts when the tooth has a problem.
Yeah.
And then your dentist recommends you to do a root canal treatment, and they tell you your tooth has been damaged to that level. Okay? If you do a root canal treatment, you have to go through stages A, B, C, D, and then go for a crown. So there's a certain level of commitment that's required in terms of the number of visits, the kind of pain that they think they need to suffer, even though it can be quite minor to us. For some people who have dental phobia, it can be quite a big thing. And then number 3, the amount of cost that you're going to put into it. And at the end of the day, it translates to how long is my root canal going to last. Okay? So for them, if you have to put in so much resources, time into this, it has to be worth it. If it's not going to be worth it, then why not remove the tooth and to move on to something else? So I think that's when the question comes into play. But then I would say every tooth is different, and most of the teeth that end up needing a root canal treatment, or actually sent to a clinic needing a root canal treatment, they're actually fairly quite good. I would say the success rate is probably 80 to 90%, can last plus minus 10 years or even longer for some cases. Yeah.
And I've had some patients also like there's not much tooth left, but they still want to save it, and it could last for 3 to 5 years, and they're totally happy with keeping it as long as possible, and then in the future just think about removing it and doing an implant.
When I tell them 3 to 5 years, I'm like, okay, my best guess 3 to 5 years.
But you'll be surprised, right? Yeah.
Oh yeah, like.
Yeah. So sometimes we are like it just looks bad, but it's not that bad. That's what I feel. Okay, and like, so the normal process would be you see a broken down tooth, and how broken down this is.
Depends on how bad the decay is, depends on how deep the crack is, and so far what we know are the information that we get from literature. So we give them like a rough hand estimate quotation of how long it's going to last. Plus, based on our experience, if you are biting on very hard food, you tend to grind and clench, maybe your survival rate of the tooth will not last for that long. So usually patients will weigh in their mind, okay, if I'm 60, 70 years old, I just need the tooth for 10 plus more years, I'm happy to save it.
Yeah.
See? Or if let's say you tell them, 3 to 5 years, but that's not good enough for me, then they'll say, okay, what else can I consider? So that's when the implant question comes into play.
Yeah, so I think like we always talk about cost, right? Then we like, okay, if you're gonna save this tooth, do a root crown lengthening to extend the grip of the tooth, and then do a crown, right? Is it gonna cost more expensive or like around there compared to an implant? Because usually, how much is a root canal plus a crown and a crown lengthening? It's about 3K, 4K. Am I right? Yeah.
Tooth type, yeah.
And then the implant is going to be about 4 to 5K. So it gets iffy, right? Like, how do you decide whether it's implant or root canal? Because root canal implants are said to, how long does a dental implant last?
I mean, on average, I would tell my patients, between 10 to 15 years, shouldn't be an issue. 15 years onwards, then more things start to happen because of wear and tear, right? So you've got things like porcelain chipping of the crown.
But the implant itself is still solid, usually.
Yeah, usually.
So how long does the implant usually last?
How long?
Yeah.
I mean, there's no stipulated, expiry date lah. Like, you reach 22 years and 5 days means it's going to drop out lah. I mean, it depends right, from case to case. Especially people who are healthy, good oral hygiene. I've seen implants 30 years inside, no issue. And then again, I also have patients. After 2 years and come back, it's like, there's like bone around the implant that's lost. So hard to say, but average Joe, I would say 10 to 15 years, shouldn't be an issue.
So 10 to 15 years, you're talking about the implant having issues or the crown on top of the implant having issues?
Actually, 10 to 15 years, I kind of lump it all together lah. So any kind of complication, be it the tooth on top or the implant below, yeah, that's about it lah.
Okay, so it's about the same longevity as a root canal treatment.
Thereabouts. I mean, at least for me, I usually describe dentistry in cycles of 20 years lah. So if you are 40 years old, you get a root canal done, right? Likelihood is that tooth should last you the next 20 years until you're like 60 plus minus, right?
And it's like buying COE, right?
Yeah. But it's not longer lah. This is right? So you're 60 years old, then at the point in time, if the tooth is okay, fine, that's it, right? Hey, we've won the lottery already because we've beaten the median average one, right? Yeah. If at 20 years, really because of wear and tear or something like that, the tooth needs to go, fine. At that point in time, then you take it out, you get an implant, should last you until you're 80.
So let's talk about this cycle. We're talking about, okay, let's say the tooth has decay, right? I hope that our producers can have an image coming up soon. But let's have a decay, right? And then from the decay, it needs a root canal, right? So we do a root canal, and that takes 2 visits for an hour or so, right? And then we put a crown, right? And then later on, the root canal has infection, maybe in the future because of some other infection, whatever. We need to redo the root canal. Redo the root canal. That's another like 10 years, 15 years, right? And then, so they really got 15 years, and then we redo the root canals maybe another 10, 15 years. That's 30 years, right? So if you did a root canal, like the start the treatment of is like maybe 20 years, so you're already 50 years old. Then no choice, you got to take out the tooth and do the implant. Then you got another 10, 20 years, right? So by the time you're 70 years old, right? It's not bad, right? I mean, like, at least you're starting from 20 years old. That means you have really bad teeth.
But most people don't start at...
They start at 30 lah, 30 to 40.
lah.
Yeah. So you would, if you do this protocol, they will have good teeth. They don't need to wear dentures. Yeah. So that's the life cycle of a tooth, I guess. Right? I think
Ideal.
Ideal.
Barring all no accidents, no
Ideal
no
lah,
mishaps
yeah.
or whichever, right?
Yeah.
I would say thereabout. So, to that end, I think that the life cycle or the lifespan of a tooth, right, is actually pretty long, and with relevance to the average person's life, lah. So let's say, right, Singaporeans mean average 85 to 90 years old, right? So as what you described, the tooth cycle, right, the lifespan of a tooth actually is very, very long. And sometimes it's just a pity, that people, tooth is broken down, we don't want to do root canal, just yank it out.
Yeah, that's what I would say. Like, there's some patients who say, I just had enough of this tooth. Just get rid of it and put an implant in. I'm totally happy with that. And then they think that implant is there forever. That's the trap that I think there's a lot of actually dental clinics and doctors also sell the fact that.
Yeah. Okay, wait. At this point, I need to face the camera and say, guys, implants are not the be all and all. I'm the one placing them, right? Okay, I'm the one. I'm supposed to be the expert in them, right? I'm telling you all right now, it's not the be all and all. Okay, it's
but
really
that's what they say. Like, I get implants in. I have metal teeth already. I have it's strong. It's good.
No,
but that's what everybody does. And my father-in-law had that. He took out all his teeth, and then he did implants. I mean, he passed away with the implants, lah. It really lasted a lifetime. But having said that, I think there were issues that I was fixing for him, like over 5 years, it tends to chip, break, things like that. Like the crown or bridge around it chips and break, things like that. And so because there's a lack of what's that term called? Like with implants as well, there's a lot more complications. You don't really see the implants dropping off, but there'll be complications regarding crowns, chipping, screw loosening, all that stuff that they never really think about. Yeah, that can happen. So having a tooth there, you won't really have the issues. I think there's less complications. You think so? Having a tooth there compared to having an implant there?
I think complications between an implant and a tooth, they're comparable. Both undergo the same thing. Loss of bone, gum recession, chipping of the crown. But you can't have a tooth that's loosening, it's screw lah, correct? Yeah, but by and large, I think they're there. But given a tooth versus an implant, complication-wise, which one's easier to fix? Tooth. Any day. Don't need to debate.
Yeah.
A tooth is always easier to fix. Yeah. So, to that end, it's like, I think when we get patients which have teeth which are very, very, kind of questionable, right? Like, you can either go down the root canal way, save the tooth, or you could go down the implant way. Typically, I think at least in our clinic, we always try to push the patient towards saving the tooth, because along the way, right, we don't want these to happen, but sometimes complications do happen, right? It's always easier to fix a tooth than it is to fix an implant.
And in terms of, because that's another question that my patients always ask, how is it, which is better, like saving a tooth, does it look better, like in terms of aesthetic compared to doing an implant? Because some people might say, hey, I have a discolored tooth, just take it out and put an implant in, it'll look nicer, because I don't want, this tooth is ugly by nature already, you know what I mean?
actually if a tooth is discolored, it's actually quite a simple problem to solve, right?
Yeah,
So
it
the
just looks
discoloration-
bad, worse than it actually is.
Yeah.
Yeah.
Discoloration may be due to decay, and then when you remove the decay, it's gone. Or if it's due to intrinsic discoloration, like the whole tooth is yellow, you just do 1 round of bleaching, 2 rounds of bleaching, it's back to normal. It's
Yeah.
non-invasive, and you get all the apart from just the tooth and how it looks like. That one can in worst case scenario, if a filling and bleaching doesn't work, just do a crown, you can mask it pretty well. But apart from just the tooth, right, what I'm finding is a lot of patients fail to realize that part of the aesthetic also comes from the gum architecture, like how it looks like. So, Darrell, do you think it's easy for you to replicate the kind of gum architecture?
I'm sure.
No.
So there you go. You get
No.
more better aesthetic using natural teeth.
Because the
Yeah,
gums will
okay,
grip
great.
more onto the tooth, natural tooth, I guess. Yeah.
After extraction, I'm not sure, but sometimes I notice that the gums actually recede, especially the ones in between. So you get black triangles, and the black holes are very hard
Right.
to build back.
Yeah.
I'm right.
Okay. Yeah. So Elyssa is right. I mean, it's not impossible. You can. I mean, there are a lot of surgical techniques nowadays, to do all these things. But you have to go through so many things. It's like you have to go through like 2-3 surgeries. It's like, and every surgery, it's a.
It's a risk and everything.
There's risks, there are complications. There's pain. You gotta take time off, etc., etc. So. Another kind of phrase, catchphrase, if you would I always say it's always easier to preserve what you have than for me to recreate. Yeah, it really is.
Yeah, I mean, coming from the fact that I actually restore your cases, that means you send me the root canal and I do the crowns, or you send me the implant, I do the crowns. Any day, if Elyssa send me a case, I will be like, I can sleep well at night. It's like,
Hey, why? I send you cannot sleep well, man.
easy. No, but it's not really. It's just the inherent nature. The implant need to build up the gums and the tissue and everything. It's a lot more challenging to do. I mean, we can do it, but it's just I need to
You
think
have to
more.
recreate
I need to
what's
think
lost.
more. That's right. That's what I'm trying to say.
Yeah.
Whereas the natural tooth there, I'm just replacing what is already there, right? Yeah, with something nicer or whatever. But yeah.
Yeah, the foundation is there. You don't need to recreate the foundation, right? Yeah, but for implants, basically you need to you start from scratch, right?
So what happens last time? When was dental implants created?
I'll say sometime in the 70s, 80s, 70s lah. Yeah.
70s,
Yeah.
and what's the story like? Was it on docs?
No. Oh, it's pretty interesting story. This guy Brenner Marx is a Swedish orthopedic surgeon. So he was trying to study blood flow, and so what he did was he installed these titanium parts in the rabbit bone, right? And when it was time to biopsy and actually look at the bone itself, he realized that he couldn't separate the bone from titanium, like it was just inseparable. So that kind of gave him the idea. Oh, okay, so titanium is compatible with bone. It actually fuses together, right? So it's like, right, the dentures are floating in the mouth. We need something to kind of anchor it down in the bone, titanium, bone, denture. Okay, yeah. So that's how it came about.
Oh, okay. So it's been a while already, lah. But before that, how do people, have what was the substitute for the implants?
What was the substitute for implants?
Like, if you want to try to save the teeth, do you like? Were they? I mean, before dental implants, what would they do?
Bridges?
Mostly bridges. So bridges.
Mostly bridges, dentures.
Dentures.
Sectional dentures.
Did they like cut the teeth and like section it and like keep one tooth?
Yeah.
The hemi-section. sort of
So very, very creative. I mean, that time, because you don't have implants, right? So you think out of the box of how to save the teeth, right? So for example, a molar has 2, sometimes 3 roots or three legs inside the jawbone. So if one leg is bad, amputate it lah. It's like you got 5 fingers, right? One finger is bad, you just amputate that finger lah. So something to that tune. Very, very creative. I don't think that these techniques are obsolete today. No, they still have their time and place. It's just that.
How's the survival rate, Elyssa? Is it very good survival rate? Not sure.
The thing.
It's not really commonly done nowadays,
There's
right?
a lot of Korean studies on it. Maybe 70-80%, 4-5 year mark. But I think
It's not bad
most
for
importantly is
keeping
case
the-
selection. You need to see the right case,
Yeah.
make sure that you amputate the right root. So choosing, even getting the right case to do the surgery is not easy. And after telling the patient that you need to do so much and amputate one of the root, the patient will be like, if it's not going to last, maybe I won't do it. So it's very hard to get the right case on your lab to also study it.
Yeah, and you actually there's a lot of unknown because you don't know whether there's crack there and all
And
that
if the
stuff.
patient had a crack to begin with, most probably they have
Mm.
very heavy functioning dentition, right? So if you have 3 roots, you remove one, it's like, the balance
It's like
not
2
quite
legs,
right.
yeah lah.
Mm.
So the other 2 might be also very prone to fracturing. So case selection is very, very important.
So based on that, right, there's a very interesting, I think this was 80s or 90s, right? This guy, Langer is based in New York, very, very famous periodontist. The other guy across the pond, Cannavale, based in Italy. So both guys, right, looked at these hemisected teeth, or rather, teeth which are cut into 2, and then you take out one root, the other root replace, you crown it, whichever. One found that his side, his failure, right, was always because of decay, of just
the remaining
re-decaying.
tooth lah.
Yeah, the tooth, whatever that's left is just re-decayed. The other guy was like, oh, actually no, my success rate very, very high, And then it kind of boiled down to, one guy had like this expert prosthodontist who only did like, these kind of things every day, he's like, this guy is just that, but the New York group, right, it's like, the
hospital
dentists that
yeah.
did it, right, they didn't do it every day.
Okay.
So technically they weren't as sound, or they weren't as familiar with what to look out for and all that. So it kind of basically goes back out to what Elyssa said, like it's down to case selection, it's down to the presenting situation. What is it? If selected properly, really, it's a very, very feasible option.
I personally have not done it before.
No.
I mean, because I think that I'm just going to lay it out there. Because most patients are just going to say, hey, if we're going to spend so much money try to keep this tooth, I just might as well just do an implant at that point of time already.
Yeah, I can see
Yeah.
where they're coming from.
Yeah.
Yeah, unless it's like a very young person, which we should come to that topic as well. At how young can they be to do an implant? I mean, dental implants.
Well, not young. Okay, so right, I think initially, right, people, I think early in the 90s, right, people didn't really know much about this, right. Say teenagers or even like early 20s or whichever, they would do it. And then down the road, right, 10 years later, right, you find that the implant, the tooth, the position of the implant doesn't change because it's anchored in the jawbone. But all the other teeth, right, because teeth in our life, they do move, right? Mm-hmm. So all the other teeth move, or what we call relative growth, right? And then what happens is the implant looks super short, and then the rest of the teeth look, a lot longer. Mm-hmm. So we go back to the growth study. So people are looking at human growth pattern, right? And you found that actually, right, by the age of 30, right, you continue growing quite significantly until the age of 30, even past puberty. A few factors, right? So women tend to grow a bit more jaw growth than men. Things like your jaw angle, right? Some people are a bit square face. Some people are a bit, like me, a bit oval face kind, right? Yeah, all these
Oval,
yeah, oval or sharp. Yeah, right.
I thought just baby fat.
All these factors do play a part in terms of like relative growth at the end.
Yeah.
So, as in general, I would say below the age of 30, we really try not to do any implants whatsoever. We really try not to. All right. Over the age of 30, I mean, there's still that risk. There's still that risk that, maybe you belong to that super subset that still got a little bit more growth,
How do you
from 30
know?
to 40.
How do you know?
I feel like I'm still going.
Still
I am going sideways.
Sideways. They're not counted lah.
How do you know you're still growing?
Yeah.
How do you know you're still growing? You don't know.
I'm not growing taller. Sometimes I just like,
But they say you're still growing even though you are like after puberty. Yeah, very slow rate.
Sorry. One way to look at it, right? It's
Yeah.
like, okay, so you see, right, our enamel, right, goes through wear and tear. Right? It also depends on what your diet is, right? If your diet is very hard, naturally your teeth you wear a lot faster, right? But so something called dental alveolar compensation, right? So when your teeth wear, when the enamel wears, right, the roots, or rather the tooth grows out of the jawbone to maintain the bite. So when the tooth grows, it pulls the bone a little bit along with it as well. But the implant doesn't move on.
But that would happen throughout life, wouldn't it be?
It happens, yeah.
So I mean, for natural teeth and root canal treated teeth, there's no issues because it will grow together, right?
Yeah. So what I'm trying to say is that, if the teeth kind of wear out and everything, the teeth would naturally grow, but then the implant doesn't what? It doesn't move on. So all the remaining teeth, the surrounding teeth, they move, but then the implant, because it's stuck in its ankylose or stuck in the jawbone, it doesn't move. So relatively, it stays there, but everybody else moves. So that is one, I would say that's one possible phenomena. The other one, of course, is like I said, relative jaw growth law.
Yeah.
Actually, a common scenario I can think of is, right, for root canal, most of our patients that come to us that are relatively young, it's because of dental trauma. They fall down, damage their front teeth, either during CCA, sports, somebody hit them, fall off the playground slide, and then they damage their front teeth. And sometimes the damage can be really bad, like the whole tooth is just broken, leaving just the root. Or the whole tooth comes out and then they plant it back. There's a lot of complications.
Yeah.
So the most common question that parents and the patients will ask, why do I have to save the tooth that's so broken now? Can't I do an implant or something else? And they come in like primary school, secondary school, way below 30. And then same thing, I agree with what you say. Implants, you're too early, don't do it because for the reasons you have mentioned.
Yeah.
And so for these patients, it's all about buying time. And even if the tooth is bad, there's a lot of things we can do just to buy time.
So how young can a root canal person do a root canal treatment?
Even if you are a toddler, you can do some sort of root canal treatment for your baby teeth.
Oh, okay.
Okay? Let's say for adult teeth, some sort. Adult teeth, they usually come in about 6-7 years old for the front incisors. Usually if they fall down when they are relatively quite young, sometimes their bone is a bit soft, the impact will not be so bad because the bone absorbs some of the
Stress,
shock.
yeah.
But those that really fracture their teeth into half and it falls off, no choice. We can do root canal treatment, but my line of treatment, we will always start with something more conservative. So if the fracture is just a little bit, the nerve is majority of it is still quite okay, we'll just do vital pulp therapy, which is just a medication and a filling.
Okay.
But if let's say the nerve is very damaged or the tooth...
And that's to keep the tooth alive, right?
Or if really no choice, we just want to save the shell of the tooth, then we do root canal treatment. But by and large, they are very treatable, and I would say you don't have a choice. It's between that versus extraction, and if you extract, you're going to have a whole lot of problem because your bone is going to shrink. So we don't even do dental extractions for young kids if they were to lose their adult teeth. We'll do what we call a decoronation. It means we leave the...
So you bury the root inside.
to buy time.
Oh, so is that still commonly done at...
Yeah, definitely.
Okay.
If they have a broken tooth that is unsalvageable before puberty. Because like what Darrell says, too young for implants.
And I think so to summarize, I think for root canal, it will be like, as long as they're manageable,
as long as can do, just do it.
As long as they're compliant, they can stay on the chair, it's good to go, right? There's no like lower limit. All right, cool. Now I have a few questions. The first being, if let's say, we talk about replacing the teeth. What if we don't replace the teeth? What happens at a point of time? Like, some patients might say, hey, look, I really don't need that tooth to chew, or I don't need that tooth at all. I get that. I get upset, right? But because the effect of missing teeth would cause problems like occlusion, the teeth are going to move around, and there's more stresses on the teeth as well, right? In terms of root canal treatment and dental implants, which one can bite stronger? That's what people always ask.
To address your first question, like how if you don't have that tooth.
Yeah.
So a lot of patients will tell me, hey, actually,
difficult questions today.
Canal treatment, can I just extract the tooth? can, it's an option.
Yeah.
But it's irreversible. So once you get it extracted and then you tell me you regret it,
They can always do a root canal first, and I know it's not nice, but at least do a crown later on when the budget allows and things like that. At least keep the tooth for now. You know what I mean?
Yeah, that's what.
Yeah.
And sometimes if they really can't make that decision, take 1 or 2 weeks to consider. Then when you're ready, then come in for the root canal. You don't have to decide on the chair. But extracting it on the spot, on impulse, is not recommended because sometimes even after extraction, you might not be able to receive an implant if that site doesn't allow. Correct me if I'm wrong. So usually I tell my patients, you think first, once you extract it, there's no going back. And sometimes doing an implant may not be as simple as it sounds, depending on your medical history, how much bone is left. If there's a bad infection over there, you need to wait for the infection to settle down.
Yeah. Yeah, actually there's another thing that is very big thing. Yeah, there's actually one very big factor that my patients always think about is that implants take a long time to get it done. It takes can be a year, from 3 to 6 months, 3 to 9 months to get it done, or 3 months to 12 months to get it done. Whereas for root canal, it's like within a month you're done.
Or less than that.
Less than that as well, yeah. So that's the factor that I think that is very important to note, is that it takes a long time to get a tooth for an implant. And also is there higher complications with dental implants?
Higher complications.
Yeah, like early stage complications.
Early stage complications. I won't say that there are higher rate of complications, but I will say that there are definitely more variety of complications.
Because you're more to do with the body, healing and everything.
Okay, for example, right? So say, for example, right, like, you see, just to say, correct me if I'm wrong, right? Root canal, okay, one of the major complications is, some bug is,
Left behind.
all right? Then the patient gets an acute flare-up in between appointments or in between the first and second stage. Pretty much, I think that's it, lah. Other than the patient go outside, take a chicken bone and go and bite on the tooth. But
that's actually, but actually, right? That's actually depending on the skill level of the root canal specialist.
A lot of factors, not just.
I mean, that's heavily dependent,
everything's dependent on me.
But it's heavily dependent, for
calcified canal, stuff like that.
But for example, a missing canal, that's.
Okay, there's 2 factors: patient factors, clinician factors. So, for example, if a tooth is very calcified, difficult to treat, of course you will try our best, but there's always the simple cases that still cannot heal. Then you keep asking yourself why. It's so straightforward. Why is it not healing? Oh, actually, it's due to a cyst. That means it's like a balloon-filled pus that has to go through a surgery. So things like that are beyond our control. So as much as you have the best equipment in the office, we will never get 100% success rate, but we always strive
Try to make the maximize it.
The success rate, honestly, some studies are putting high 90%, high 90%, plus minus. So actually, pretty good,
In your case, it's about 90% also, right? I mean.
Yeah, but like I said, variety of complications. Surgical complications, bleeding, you hit some anatomical structure, patient swells, right? Pain. And then after that, the implant doesn't take, or implant doesn't, integrate with the bone, right? Then, or even late failure as well. So you mentioned something about, patient will ask, is a biting on the tooth or the implant stronger? Okay, I mean, guys, from an absolute standpoint, of course, the implant is stronger because it's titanium, right? But there's something called implant overloading as well, right? In other words, if you bite too much and too hard, there comes a point where the bone says, okay, enough, guys. I don't want this anymore. I'm going to let go of the implant. And then the implant drops out. Yeah, so
because there's no nerves.
There's no
reception,
So there's no sense of pressure, or rather the sense. No, wrong. It's not there's no sense of pressure, but the sense of pressure is a lot less. Yeah, because
there's bone to implant. There's nothing.
So the ligaments that hold your tooth in place, right? So ligaments have pressure receptors. Same like how you have a ligament holding your wrist to your forearm. If I stretch it like that, right? Here it says that, okay, there's a lot of pressure. I'm getting stretched, but bone itself, right? You try and bend the bone, right? Yeah, bone has very little pressure receptors. So in that sense, then people be like, oh yeah, I feel great, man. I'm biting like rocks.
Yeah,
right?
yeah. They just
Yeah, I'm right.
there was one
Crab
time where I
shell.
had a patient. I did
Right.
5 implants for the patient, and then the next day he was eating crabs. He like said, I never like biting shells. I never bite shells for like the last 20 years, and I finally can do it. Now I'm like, dude, no.
Yeah.
I mean, you still gotta take care of it, I guess. Yeah.
Yeah. So, an implant is like it's actually once you get it right, you have to treat it like a normal natural tooth. You really kind of treat it like that way, right? But to answer your question earlier on, yeah, really, I think there are a lot more. Success rate is high. Don't
Yeah.
get me wrong, but variety of complications. More
More lah, more. Okay, now we talk about the lower limit of the root canal treatment and dental implants. Is there an upper limit in terms of age to get implants and root canal treatment? For root canals?
I think the oldest patient that I've treated so far is 94 years old.
Wow.
Yeah. Okay, there's no upper limit. And in fact,
There's no medical history that can actually prevent you from
Contraindicate.
doing it as well?
usually for such old patients, in fact, their medical history tells them not to extract the tooth. So, for example, in the elderly, they might be on a lot of medication for heart problems like blood thinners. They might be on medications for osteoporosis. This affects their bone in general, including the jawbone. So you don't want to extract the tooth to get a complication known as MRONJ, medication-related osteonecrosis of the jawbone. So usually the letter detailing all this medical history will be like, oh, please check out her dental infection. So when we go through the options, we will go through, hey, yeah, you can do a root canal, but extraction, no, that's off the charts because you might have some problems. So in fact, the root canal indications might be higher for older patients.
Oh,
For
okay.
older patients, they come with their own set of challenges. They understand the treatment that is required much better than, let's say, a young child.
Because they've probably done it a few times already.
But they are all very scared across all ages. And then
Yeah.
the challenge is, because when you're old, your nerve, the pulp in the center of the tooth has gone through so much wear and tear. It has its own natural defense to like block itself out by laying more calcification. It's like defending itself against the decay, the cracks, the insults coming in. It's super calcified. It's so narrow and it's very difficult to find. Thank goodness we got the microscope. So that really makes like life way easier compared to the past, and it reduces the complications. Not like there won't be complications, but the rate of complications maybe 1-2%, 2-3% at most. And most importantly, we will always tell the patients, look, your tooth is difficult at the consultation stage. If you want to save it, please be patient with me. If you cannot take more than like an hour on my chair when I need it, don't worry, we do multiple visits. So as long as you're comfortable, we will get it sorted and we won't extract the tooth. So really there isn't any upper limit. And in fact, since I started doing root canal treatment from years ago till now, I'm finding that the older population is more keen to save teeth as compared to the past. Because in the past, you're like, oh, every time I have a problem, I'll just go to the dentist to extract it.
Yeah, the old school style. Yeah.
Now with more dental awareness and the medical doctors are even sending them for dental checkups before their medical treatment, more of them are realizing, hey, actually I can solve this problem and I don't need to get an extraction done, or maybe I'm not even suitable for an extraction, so no choice, I have to do the root canal. Yeah, so no upper limit at all.
What about dental implants?
Dental implants, no, there's no. I always say, as long as you got a beating heart, can got bone, got beating heart, can. No, but I think no upper limit, but usually.
So you integrate, if let's say a very healthy person, you integrate at 95 years old.
Yeah,
It's fine.
It will.
Okay.
So long as the bone can heal,
Yeah.
it will integrate. Of course, older people will probably take maybe a little bit more time. So naturally, I mean, because things are a little bit slower, right? So for somebody who is healthy, maybe we'll say we wait 3 months before loading the implant. Somebody who's a bit older, maybe wait a little bit longer, maybe 4 months. But that is just an arbitrary clinical decision. It's not something which is like, oh, hard and fast rule. Once you are past 80 years and 82 months, kind of thing, right? Yeah, then, yeah.
Yeah.
So, but back to your question, no, there's no upper limit. The upper limit is usually the the upper limit is usually limited by the patient's medical history. So naturally, I mean, as we all grow older, we all will have some kind of medical issue, right? Some kind of medical comorbidity or complication. For example, like she mentioned, for women, once you pass menopause stage, the risk of getting osteopenia or osteoporosis a little bit higher. Then they go on these bone medications. Then that will make them, I wouldn't say unsuitable, but not a great candidate for implants. Yeah,
Okay.
because the medication interferes with the bone healing, so it will interfere with the integration of the implant as well.
Okay, so it's more like for implants because it's a more surgical aspect to it.
Correct.
So there's more like medical history that can interfere.
Correct.
So what are some medical histories that you mentioned? Osteoporosis.
So osteoporosis is one. Uncontrolled diabetes is another, because that affects the healing potential, of the person. Other things, smoking. Smoking is lah.
What's your take on smoking? Because I mean, smoking has
the fact that Lawrence
prevalence.
Wong increased the tax last week was great, man. Yeah, but probably means less business for me.
Yeah. But smoking is not like a be all and all, right? You can still smoke and the implants will still do fine.
Wow,
I mean-
Justin, that's a very loaded question.
I mean, I've done implants on smokers and they have been fine. But there are some precautions that you have to take for smokers, right? Like you have to cease.
Yeah, stop
cease-
smoking.
Yeah. Oh, but no, it can be also like just like momentarily, right? It doesn't need to be all the time. So you can cease for like a couple of months before or something like that.
So
There's a program on it,
there is
right?
there is no guideline like, oh, you have to stop 2 weeks or whichever before.
I thought there was a program, like a few. There's
Yeah.
some anecdotal.
Yeah, it's some institutions or some places on earth, some countries right. Some clinicians they do have this thing like, oh, stop 2 weeks, stop 1 month before, and then no smoking for 2 weeks after the surgery, etc., etc., etc. But the thing is, you stop, right? But the nicotine and everything is already in there already. The vasculature, the vessels in your mouth are already kind of semi-damaged already. So whether you stop, unfortunately, I don't think.
I just say,
holds,
let's continue lah.
No,
no
not
difference
continue but if you can, stopping is really the best thing lah.
Wait,
but
and does changing to a nicotine patch have less side effects compared to smoking?
yes. So there are studies done on this, right? So basically, the act of smoking, the act itself,
The
of-
tarik.
the tarik, the tarik, right. The act of smoking itself, that is actually what causes a lot of the damage.
I didn't know that.
Yeah, so it's not the nicotine per se. Yeah, because smoking itself, there are a billion other chemicals inside. It's not just nicotine.
Yeah, it's true.
Yeah. So yeah, it is the act of smoking. It's not so much the nicotine itself lah.
Very interesting. Very
Yeah.
interesting. So we covered smoking, diabetes, heart disease.
Heart disease. I mean, heart disease. Usually, patients are on blood thinners.
Okay.
So so that is a surgical complication itself lah, or rather contraindication. So depending on what kind of blood thinners you are on, then we might have to coordinate with the cardiologist, see if you can stop for a short period of time, 2-3 days kind of thing, just to allow us to go through the surgical phase first before the patient resumes. But nowadays the factor 10A selective, so rivaroxaban, epaxaban, all the exaban, all the ban, yeah. Those you don't have to stop because those are just selective,
Inhibitors.
Yeah.
Okay.
So it's unlike warfarin. Warfarin, the older generation.
Warfarin and aspirin.
Yeah.
Aspirin not so bad, yeah.
Aspirin's okay. Yeah.
Yeah.
But warfarin, this kind where you really throughout the board lah. So factor 2, 7, 9, 10. Yeah. Everything. Zoom. Yeah. So that one, once you take it, right? Yeah. That's it. You get a cut. It's bleed all the way. It's this. Very difficult to stop lah.
And what happens when you see a patient that keeps on bleeding?
Wow.
It's-
You apply
I mean, it's
pressure
definitely-
and you just spray and hope for the best.
Yeah.
I mean, of course,
there's different
other things
procedures
you can do.
Yep.
You can
Yep.
you can inject adrenaline there.
Yeah, you don't get
stuff
all
like
these
that.
issues with root canal, right? Because it's like
She's like, oh yeah, no.
Most of them, when they're older, they'll be like, oh, okay, yeah, I'm on so many medications. Root canal is
Yeah.
supposed to go.
yeah, actually you're right. I didn't think of that. It's
When
actually a
you're
very
older, you
convenient
use
thing.
root canal over like extra.
And there's no downtime at all because like once you get a root canal done, you can put a tooth there, you can replace the tooth already, rather than like
Not much issues with all
bruising, swelling, kind of thing.
Super
Yeah.
okay.
So I always tell my patients that there is a prime time for you to do an implant, like around 50 to 60, because like before you get any medical compromise, like you get diabetes, heart disease, all that stuff that will cause you to not be able to be the best candidate for implants, right? So I say you better think about it now. This is talking about already missing teeth already lah. Yeah. So then that's the best option. Yeah, because you don't like I got this auntie, right? I remember this auntie. She's like just waiting. I say you cannot wait too longer because then you now have nothing on your medical history. The more you wait, then you once I have something there or you have osteoporosis or whatever, I can't do an implant for you or do it. It won't be as good, basically.
It won't be as complication free.
Yeah, which is very important. Yeah. Okay, cool. And I got these questions with regards to Singapore and cost. What's the average cost of an implant in Singapore? And why is there so many different prices? You see so many different prices out there. I know it's a loaded question.
This one,
And yeah.
okay lah. I think the
Okay,
honest
apart from the
truth is-
skill of a dentist.
Okay, the honest truth is, in a way, it's a little bit like cars like that lah. In a way lah. Right?
Okay.
Whether you drive, okay, let's not name,
Brands lah.
Yeah lah. Whether you drive a simple car or whether you drive a super car,
Yeah.
right? Hypercar, supercar, whatever you want to call it lah. They both will bring you from point A to point B. Of course, the supercar may bring you a bit faster lah, but at the end of the day, you will get to your destination. So I think same with implants as well. Implants got many different manufacturers across the globe, right?
I think like 400-500 of that, even more than that. Yeah.
Justin, I have no idea lah.
Yeah.
But yeah, it's everywhere lah. So
But the problem is that there's so many different brands and they all use different parts.
yeah, correct.
Yeah.
So different companies have different philosophies, depending on who their researchers are. So they believe that the connection, the internal connection, the engineering, right? Of they believe in this versus believe in that, blah 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 blah. So that drives their design for the implant, right? So to answer your question about why there's so many varying prices, is because again, some companies use different kind of alloys which cost more money, right? QC, right? So some companies are quite really strict on this. Some are a little bit, I guess, a bit less strict, right? So all this adds up, yeah, lor. So, and then of course also down to business point of view, right? So different clinicians, obviously, you're willing to take kind of like a loss leader philosophy, I suppose.
And are the sort of the day-to-day regular car, are they less effective compared to, what's in it for the patient to buy a more expensive implant compared to a more cheaper implant? I think that's what they would like. I'm sure patients come to you and say, why is your implant price this price compared to another person who's this price? Like, is there? To me, it's usually because the fact that the cheaper implants are not well received, well manufactured. Number one, number two, maybe it's also the fact that it's not a global implant.
Am I allowed to say the brand that we use here?
Yeah, we can use it. Let's say yeah.
I'll just say it out loud, right?
Yeah.
So, our clinic, we use Straumann. So, Straumann is the only company in the world, right, that uses a titanium zirconium alloy because of patented technology and everything, right? And titanium zirconium alloy, it's stronger, much stronger than Type 4, even a Type 5 titanium implant, but without all the, because the cornea itself is biocompatible with the human body as well. So without all the other, things like, okay, so difference between type 4 and type 5. Type 5 is just less pure titanium. So they put in other elements inside to make it a stronger alloy. But the problem is that these alloys, right, sometimes they are they may not be as biocompatible to the human body as, say, titanium. Then you get things like corrosion products happening and stuff like that, right? So, titanium zirconia alloy, you actually surpass that problem because both elements are biocompatible with the human body. That's number one. Two, it's stronger, right? So, listen, if I'm going to put something in your mouth, right, I want to know that, I'm giving you the best thing that there is on the planet, right? Because
Or similar.
yeah, right, all similar.
similar.
Yeah, right? Because I'm not going to put something in your mouth and then like with the fear that if Justin goes out and bite like a bak kut teh or something like that, or like boneless chicken rice that has bones inside, right? Yeah, chewing happily, then like right,
Yeah.
and then the whole thing fractures, and then you come back, Darrell, I thought you see this implant very strong.
Yeah.
It's like, right, yeah, I want to do. If I'm going to do something, I'm going to give you the best thing. So that I can sleep, it's a bit self-serving, but
No, but it's both.
so that I can
so
sleep properly
everyone
at
can
night,
sleep.
lah.
Actually,
Yeah,
everyone can sleep. So yeah, and I think the cheaper implants would cut down on certain things that may affect it. We never know. Until when something happens, right?
yeah,
Yeah. So that's the biggest issue, and I think that because we see a lot of international patients.
yeah.
Straumann is well known, or like a
Yeah,
similar
yeah.
brand.
Yeah. So
yeah.
I think that's the other consideration as well. I mean, overseas patients, because if they don't reside in Singapore for the rest of their lives, right? Or they move back to some or they move to some other country. You want to pick a brand that is available worldwide, right? So that in the event something happens to the implant, you need to change some part of whichever. It's easy for them to get a replacement rather than them being stuck, right?
Yeah, because I had so many patients coming in and they show me this Zapalang, some random implant brand. And then I'm like, can you put a crown there? Because my dentist is in somewhere else, far away, and I can't see him. But this is the brand. I'm like, what brand is this? I gotta Google it. Oh, I don't have parts here. Or Singapore doesn't have a sales representative here as well.
Yeah.
That you can't even order from them.
Not HSE
You can't even,
approved
you
kind of
can't
thing,
even order from them, or you gotta buy online and then they gotta ship it and then it's not even approved by the HSA, right? Because of that. And so often a lot of dentists will just reject them and say, hey, I think it's better for you to just go back and see your existing dentist over there. So and that's the problem because they don't understand that an implant, even though it will integrate, the bone doesn't know what implant brand it is, doesn't know whether it's made from Switzerland, Korea, China, Japan, whatever. They don't know.
You should just put a little
Made in-
word there, then you can use something.
Yeah.
If you buy
Then you see a
glasses,
bone be like made in Switzerland.
then you scrap the date it was sunk.
Laser
Yeah,
etch inside there.
Then you can borrow
Yeah.
my microscope to zoom in. Like,
Oh my
okay,
goodness.
This is the brand. This is the size. This was when it was done.
Yeah.
Cool idea, right?
No, I mean, well, at least Straumann now gives this, a warranty card, right? That has the details of the implant, everything all on it. Then, so after I'm done, once the whole case is finished, I usually just give the patient that, and then I just tell them, hey, you keep this with your passport.
Hey, I think that's what public system does, right? They have a card. No? Okay.
Straumann has. Yeah.
Okay. At least in the overseas, they have a card. They get a card with the implant details and everything because people forget, right? Yeah. Okay. Cool. Now asking about root canal treatment. Why? Does a root canal equals a root canal equals a root canal? That means a root canal done from another clinic or another dentist. Is it the same? Because with implants, it's very simple. They know, the brand, all right? There's different brands, right? There's different clinicians out there. There's different people who place. There are some people who are placing Straumann implants who are not so experienced just because they can buy Straumann implants and can place it. But it doesn't mean the success rate is the same as what experienced clinicians are doing, right? It's just, you just buy. you're just buying a Ferrari or another other car, and if an inexperienced driving it, it might be slower
F1 driver
than
versus
someone F1 driver versus
non-F1
driver. Yeah,
F1
it's just a car. It's just a car, but how you use the tools dictate the outcome, right? I think that's agreeable. But for a root canal treatment, there's a root canal treatment for clinic A, clinic B, and clinic C. Are they all the same? Because it looks to the patient, or at least when I was before going to dentistry, it seems like it's just something like a filling. I can just get a filling anywhere. Yeah.
Question. So actually, when it comes down to root canal treatment, there's a lot of factors that matter. So first thing is the materials that each clinic is equipped with. Okay, some patients who got it done maybe overseas or in a different time period, like 10, 20 years ago, material used is different. Like we have patients that just got Russian rig, which is basically a mixture of formaldehyde mixed in their tooth. Is done. I'm not sure whether certain parts of the world still use it, but right now that's recognized as something that's cancer causing. So there's also some, like formaldehyde is what you use to preserve dead stuff, right?
Yeah.
They put it
I didn't know Russian.
Wow,
uses it.
Yeah, so can you imagine all the leaky stuff?
By the way, Russian rig is nothing to do. I mean, it's
just
it's not made in Russia.
the tooth is
It's not like some spy stuff.
Some clinics they also use like silver points, but that's more towards the older generation.
Still do
I've seen, but the older generation.
Wait, they still sell it?
I've seen it just fresh in the boxes, but I don't know anybody who actively uses it. I'm seeing patients who had them done a while ago from another clinic. Like maybe they kind of tell me.
I think my dad has still have some silver points in his mouth
so
still.
like one clinic and the other clinic. This is just a very exaggerated example of how different the materials can be depending on which clinic they went to at which time point. So same time as given our current generation, more or less most of us will use gutta perca, but some of us may use more biocompatible materials, which are the in things. It's the cells are happier, you get less foreign body reaction, you get better outcomes. And so between A and B, materials do differ. Second thing is the equipment. So typically when you see a general dentist, when they do root canals, they can do it, they might do it just under the naked eye or some sort of magnification like the loupes, like you see them wearing this. But for specialist clinics, we are typically equipped with the dental microscope, which magnifies way, way bigger, and sometimes we can even see to the root of the tooth in some cases.
Because sometimes the nerves, the root canal, it's like so small that it's like, how small can they be?
So the other day, I was like
a pin
doing the molar root canal, and then I was like, okay, the microscope was a little bit far, so I was not using it. I was just using my naked eye just to do the initial procedure. I was like, okay, I know I'm supposed to find 4 canals. But one canal I really couldn't see with my naked eye, and I was like, okay, time to stretch out my hand and get it. And then once I got the microscope over, I was like, okay, it's there. You know, like you really need the microscope, so equipment really matters. And apart from the microscope, there are also different types of materials that you use to clean. So in the past, or actually what's commonly used now is the manual files, because they're easy to get, you can just clean them. But some clinics, like what we have, we use rotary files. And there's also a range of it. There's the older generation, the newer generation, which is meant to preserve the curve of the tooth, be more conservative. So things like that matter to give a better outcome. Because if you use the older materials that may be a bit stiffer for curved canals, you might thin down the tooth too much. You might even cause a perforation, stuff like that. Then apart from materials, equipment, we're also looking at the operator. So some dentists are more experienced in root canals. They just do root canals day in, day out, or it's actually something that they enjoy so much. So they read up a bit more, they practice a little bit more. So those dentists tend to be a bit more experienced. And I would say that journey, if you're more experienced, it translates to knowing which cases to treat. So for example, if you see a case at a consultation stage, hey, something looks a little bit strange. Based on my experience, this may not work out in your favor. So patients will then have the discussion with you, hey, should I move on to something else like an implant per se? And then at the same time, apart from knowing what complications, you also know how to manage it. So if let's say a patient comes, yeah, I got root canal done with dentist A, something fractured inside, and they come to us, we're like, okay, actually that material, easy to remove, we can take it out, it will be predictable. So experience really matters a lot in knowing how you're going to tackle each case. And I would say it's same for anything in life. The more you practice, the better you get at it. It translates to shorter duration and more patient comfort.
Yeah, I mean, the one of the things that I would say for root canal, right, is that actually the materials actually matters a lot, and not reusing the materials, make sure they are fresh materials, the files are fresh, new materials, so that we can reduce the chances of breakages or anything, contamination, things like that. That really helps a lot, and it's something that patients don't see, but we have to do it on our end.
It's a lot of background work.
It's a lot of background work.
Nurses
Yeah.
are doing a lot for me.
Yeah, they're running. Yeah, and then also at the same time, for like, you don't really see, like, for root canals and dental implants, the complications only come in late game usually. I mean, what I'm trying to say is that, like, for a patient to discern whether the root canal was done successfully or the implant was done like well or not, it only comes in like the
Time will tell, right?
2 to 3 years or 4 years mark. It's not like immediately the next day or whatever you're gonna like, hey, this did a bad job on me. It takes a while for it to manifest, and that's the problem, because people think it's fine, but it's actually not okay until way later in the game.
Actually,
yeah.
on that note, I'm thinking, like, I've got a fair share of cases that come to me for retreatment. In other words, it's a revision of the root canal treatment that was done in the past. So sometimes some of them are clearly, I look at them, I'm like, hey, this is clearly a good job done. How can I do better? Then we might have to think of like what other equipment we're going to use, or is it going to be an endo surgery? But for a fair share of these cases, perhaps it was done in the past where the technology wasn't good. You can tell that root canal treatment was not done that well, because it looks like there are empty spaces where bacteria could have resided that was not cleaned properly. So to me, I'm thinking, if I had a chance to get root canal done, and if I belong to somebody who doesn't like the dentist, I have dental phobia, why not get it done once
and for all, yeah.
Yeah, once and for all, get it done well, instead of like, okay, I go to this
And just pay maybe slightly a bit more to get it done well and once and for all, rather than
compared
multiple
to the scenario
times.
of like you're paying twice.
Yeah.
That doesn't make sense. So on that note, I would say between all clinics, there will be differences. So you just have to pick out one that you trust them the most, and maybe you can look at like friends'
Research,
recommendation,
yeah.
Reviews, stuff like that. Yeah. And most importantly, you have to be comfortable with the dentist, because it's going to be probably a multiple visit appointment, maybe one, 2, 3 visits. Yeah. And also get to know your equipment, whether they are suited to treat your tooth, because they might be able to do a simple tooth but not the complicated ones.
Yeah, it's true. Actually, every tooth is different anyway. So a good dentist might do the front teeth really well, but maybe posterior teeth not so well. Then that's when they know
But having
how to
said that,
refer.
I've been, so far from what I feel, a lot of dentists that I've interacted with, they always try their best for the patients. They always try their best, okay, if this is within my limit, I'll do it for the patient. And it's a fairly nice job done by them. And I've seen a lot of my colleagues who are non-specialists, they do good root canal treatment because they go for a lot of courses and they practice well. So
That's true.
It's just only a small number of cases that fail, and they so happen to require specialist treatment. So I'm seeing these cases. But
Yeah, you see more intense stuff. I don't want to be in your shoes.
Yeah, but by and large, the good stuff will come my way, you see. So I'm sure they're doing a good job. It's just that
Yeah,
I'm
I give
getting
you
the
some
pull that
single
needs a
canal,
revision.
Yeah. But the same thing for dental implants. I've seen like the thing is that like, even though the implants, the treatment might be like, cheaper, but then like the only way the patient actually knows that it's not a good treatment done is because, even like more expensive treatment, the only way the patient actually knows that the treatment was not done properly was after like 4 or 5 years down the road. But we can sort of predict really, because you'll see the crown, or you see the implant was placed too superficially or whatever reason, and then you're like, okay, in 5 years time, this is gonna have a problem. But we can't do anything about it now, because the implants, that's worse. The implant's already there already, which is a lot more harder to treat compared to just redoing the root canal treatment. It's a surgery again to remove, and it's something that I think patients don't know about, because sometimes they'll be like, some patients of mine will be coming in and say, hey, look, like, I got an implant for cheaper. And I show them like, there's a trend that is gonna fail or might fail. They don't know about it until they see another dentist or whatever, right? So yeah, cool. Now I got some cases that I wanted to show you. That I want to see what you guys think about whether you want to remove the tooth or not remove the tooth. So, and do an implant or not. So I got a really, really broken down tooth over here. I don't know whether you can see it. Over here, like this. Should we save it or should we do an implant on it?
What's underneath?
Filling.
Same
Well,
for sure.
yeah.
Save it for sure, right?
Inside.
Because there's a lot of tooth left, right? Am I right to say?
Does it even need a root canal?
Sorry?
Does it even need a root canal? It might not, right?
It might not need a root canal.
Yeah, you just can get by.
You see, this is interesting because a lot of patients think that, hey, just take out and do an implant. I mean, that's the perception that is really broken down already. But I mean, I also know lah. I mean, I'm just saying this. Okay, interesting. I just saw this case yesterday.
Is that crack?
Yep.
Ooh.
Wow. This
Should we do an implant or should we do a root canal? Or should we not even do anything?
You didn't refer me the case, so I assume you recommended extraction.
No.
he crowned the tooth, huh?
I just crown. I just did a crown for it.
Oh, okay.
Because the tooth was vital.
Okay,
and the crack was
Vital?
not. The tooth is vital. Yeah, the tooth is vital. So I just did a crown.
Okay, I think it's this is
Because this is a common question, like crack, right? And then be like, hey, where should I do an implant or should I do a root canal or should I just do a crown?
this is a very detailed conversation that has to be had. Sorry, with the patient.
Yeah.
In the sense that, okay, look, a cracked tooth, right? You can never ever fully kind of predict or say, okay, I do a crown, the crack's going to be contained, because I think we've all seen cases where a cracked tooth crowned already, and then a few years later, the patient turns up with the crack propagating down into the root, and then the whole tooth is split into half, right? But the crown was there, and the crown is supposed to prevent that from happening, but still, the crack propagated, right? So I think we can all accept that, a cracked tooth is like a bowl, a porcelain bowl with a crack. You can never fully mend it, right? No matter how you glue whichever, you can never fully mend it. The only way to mend it, right, is to redo. I mean, remake the whole bowl, right?
Yeah.
Yeah, so put in the furnace, right? So therein, with that in mind, right, then the conversation then goes like, the following, that, okay, hey, Mr. So-and-so, you have a cracked tooth, right? This tooth right now, frankly, it's still, the nerve is still okay. I think it's still salvageable, all right? However, that being said, we cannot, 100% say that this crack can be contained. This crack might get worse down the road, at which point, it may go into the nerve, may require root canal treatment, or worse still, the crack may go into the foundation, the root area, at which point the tooth will be deemed not salvageable. Okay, so this thing may happen down the road. We don't know when. All right, can be 2 years, can be 7, can be even 15 years. We don't know. All right, but there is a chance of it happening. Alternatively, if you don't want that, all right, if you don't want to have to deal with this down the road, then the next option is to really, like I said, redo lor. In other words,
Take out the tooth and
yeah, out comes the tooth and then in comes titanium lah. But of course, you have to bring in other factors, like things like the age of the patient, right? How likely is it going to happen? Like, if the patient tell you, Justin, I swear for the rest of my life I'm going to eat porridge, then this will never happen. The crack will never ever propagate, right? Yeah. So other factors are right. So I think at the end of the day, it boils down to what the patient deems as the most comfortable or the most suitable. Like I always tell them, you cannot ask me, because I work in the dental clinic. If I have a cracked tooth like that, right, I would for sure 100% save it, because if 2 months down the road I still have pain, I'm just going to go to Elyssa, which is next door. Hey, Elyssa, my tooth got pain, right? Yeah.
You eat porridge for the rest of the life.
Or that lah, right? Yeah. So you can never ask us as the dentist because I think we're all biased in that sense, lah.
I mean, we
right?
have very good access to dental care. lah.
Yeah.
Unlimited access to
We
dental
spend
care.
half the day in the clinic, you know. So if it has to go down to them as a patient, right? You have to kind of consider, okay, am I willing to take? No, I won't say take this risk, but am I willing to? Well, okay, fine. Let's save the tooth, and if the tooth has issues, you know, be it 2 months, be it 7 years on the road, am I willing to take time off, come back, etc., etc., etc.?
Okay, so let's assuming that this tooth is root canal treated already. I mean, not root canal treated. The nerve is dead. Okay, I think it really depends. It boils down to the budget of the patient, right? So the patient's like, okay, if the crack is, you know, and you do a root canal, you see a crack there, are you willing to spend X amount of money to save the tooth for maybe a couple of years before you need to take out the tooth and placing an implant there? Am I right?
I mean, ideally, I would like to take financials out of the, you know,
But it's
the
always
picture,
there.
lah, right? You know, we try
I
to do things the ideal way, but again, yes,
Yeah.
we don't live in an ideal world. We live in a practical world, right? And exactly what you said, financial consideration is a very pertinent or very, very important aspect. So like what you mentioned, some people is like, oh, listen, if I have to do the crown and the root canal, it's going to cost me 4,000, and implant is going to cost me 4,000, right? I might end up spending 2x instead of just one time, you know. So I no right or wrong really, it's
no right or wrong. I think it's a
whatever floats
conversation
your-
that you have to
Yeah,
have
whatever
with your
floats your boat,
dentist. And I think that the dentist needs to orchestrate the whole entire conversation with the patient to facilitate the options that they can have. Not just like, hey, implants are the best, implants are the best, or root canals are the best. You know, like there needs to be a conversation between the patient, and the patient needs to take ownership of their problems, I guess. Yeah.
I think it's all about managing their expectations. Because I had a very similar case like yours needed root canal, and the crack actually not only had a vertical component but a horizontal component. So I told the patient, hey, look, it really looks bad. Would you rather me send you for an extraction and an implant? But the patient was like, no, even if the odds are not in my favor, I quoted some numbers.
May the odds be
Yeah.
ever
And
in
then
your
she-
favor.
Yeah, then she's like, okay, I'll still go ahead. Now she's really happy with the tooth, got a crown done, but she's aware she has to come in for regular reviews so that once there's a problem, we will pick it up early enough. Because the next issue is, I think what they don't realize is once it's done, it's pain-free. There could still be problems, and we also want to follow up.
So it's maintenance, lah.
So
Yeah.
it's maintenance, and most of the time, apart from chewing hard food, which is something they can control, they always grind and clench their teeth. So they also need a night guard for some sort of protection.
Singapore stress.
Yeah.
Singapore very stressed, and also the diet, lah. The diet is for bony,
All the nuts.
cartilage,
Now Chinese New Year period.
soft bone, no kind of stuff.
Wow.
Yeah.
I don't know why,
yeah,
man.
yeah.
It's
true.
a
It's true.
crowd
It's true.
favorite.
So what are the maintenance programs like for root canal treatment? Like, do you see them every 6 months? Do you want to see them?
Usually after root canal is done, I tell patients to come back every 6 months. The first review will be at 6 months. I see how they are doing, whether they got the crown done. Some of them still they might not have gone back to the dentist for a crown. They're like, oh, I feel fine, your filling is great, I have no problems. They don't do a crown. So that's when you have to check in on them and make sure the crown is there. Okay, then apart from that, we usually do our clinical tests to make sure the tooth is symptom-free, no pain, in function, they are able to chew on that area, and also we take an x-ray to make sure the infection has reduced in size. So most of the time when the patients come, they come with a variety of symptoms. Some of them have pain, they have swelling, or some of them just have a black shadow around their root tip on the x-ray, which is otherwise asymptomatic. So I always tell them there's short-term improvement and long-term improvement. Short-term improvement, if let's say you're having very bad pain, in between the visit 1 and visit 2, you get an improvement. Yes, I know you're doing well. But long-term wise, for the infection on the x-ray to improve, I need the bone to start depositing in so that we can see the dark shadow fading away. That means the bone is not so hollow. For that to happen, we need time. Okay, it takes time for infection to develop. It takes time for it to improve. So the 6 months review, we take an x-ray to check on that. And if they're doing quite well, then I'll lengthen the next review to maybe about 6 months to 1 year later, depending on how it goes. If let's say they are seeing the GP on the same visit, okay, and I'm just next door, okay, pop by,
Yeah.
save the visit. It doesn't have to be strictly 6 months or 1 year mark. It can be somewhere in between, not an issue. So these are things that we want to look out for, because if they should ever fail in the case of a cracked tooth, which can be quite unpredictable, then I want to pick it up early, because I don't want there to be progressive bone loss that will compromise a future implant site. So if time is up for that tooth, I will tell you time
It's up.
Then we might have to consider other options like maybe a root canal surgery or extraction, but it is good to always check in and not to assume you are doing okay just because there's no pain. I think that's something we all agree with.
Yeah. What about dental implants? What are the maintenance like?
Depends on the risk profile. So, if you're somebody that has a history of previous gum disease or diabetes, smoking, preferably not lah, right? Then we see you on a much stricter frequent recall, like maybe every 3 months, because 3 months is a long time. It's 90 days in between visits. So a lot of things can happen in 90 days, right? So at the earliest signs of something developing, we want to pick it up and arrest it, because as I mentioned earlier, complications around implants way more tedious, difficult to treat, right? So if it's starting, you want to really nip it in the bud, right? For somebody else who is healthy, average Joe, no medical issues, no risk factors and everything, then I would say every 6 months, 1 year, definitely. 1 year at the minimum, at the very, very minimum.
Is it like a implant review itself, or can it be paired with a clean?
Paired with a cleaner. So I usually would say just do it together with your routine cleaning.
Okay.
Yeah.
Okay, cool. I got another case. Last case. No, actually two more cases.
Atomic bomb or something like that.
No.
Ooh.
Save or take out?
What's the age of the patient?
What's the smile line?
See, there's more questions needed, right? So you cannot just show, the patient cannot just send us a photo and just do a diagnosis, right? Yeah, same. But yeah,
it's tough,
what do you think? Should we save it or should we remove it?
How old is the patient?
Let's say the patient, I don't know, I just got it from Google. So let's say the patient's 35.
What is the root length, remaining root length,
Let's say
smile
it's
line?
Okay lah, it's okay.
Bro, what's okay?
Still,
okay can be 8 millimeters. Okay,
like
can
here.
Okay, so assuming
like a
longer than
average
average root,
Yeah.
I would say that we can
Save.
probably try to save the tooth. Darrell can trim away some of the gums, make the root expose a little bit more, do the root canal, put post, which is a foundation side, put crowns. We can still save the tooth.
Okay, generally, even in let's say, assuming all things considered, this patient healthy and all that, young patient, I would actually say orthodontic extrusion. Okay, let's say if the smile line is very, very high already, right, and if we cut away some of the gums and the teeth are going to look really, really, really long
and bulky,
right? Yeah. Then another.
So your call is to think about really. You guys are really trying to save the teeth.
Yeah.
Yeah.
Another thing would be just to extrude the teeth and then try and save them.
Okay.
At the end of the day, I think it's also whether a patient can maintain. Because if you're looking at this,
It's quite dirty, right?
Yeah, the oral hygiene isn't great. And if the patient is very committed to maintaining it, like going to be a changed person from here onwards, then okay, I think it's worthwhile putting in so much effort. Because I need the patient to be very committed also for my root canal to be successful. But if let's say they're not going to change their old ways, I'm not sure whether so much work is going to be warranted in somebody who can't maintain it. Do you agree?
Denture, though. But actually, arguably, people think that denture is very easy to maintain. But actually, denture is it's not easy. So, yeah.
I think the bite is quite.
So I think
bad
either way, whichever way you go, right, the patient has to own the issue, like you said,
Yeah.
The patient has to recognize that this is. I mean, you brush the teeth that you want to keep,
Okay, this is another one.
No man.
Would you save it?
No lah.
Depends on the medical history. You see, it's an old person, for sure. So you have to check the medical history first.
Oh yeah, that's a good point. Good
Okay,
point. Yeah,
fine.
Good point.
Fine, but from a
Strategic point of view.
from a restorative point of view, right?
No. We might not have to keep the whole tooth. We might be if
Just
we can't do
bury,
extraction, we can decorrelate it. Then your denture can sit on top of it. It's still doable. That's
I
what we
mean,
do
the
for
tooth looks like
orthodontics.
it's already
But I wanted to say
like
because
mock three,
this
gonna-
might not be a warrant for root canal treatment if let's say there's no medical history issues.
I've seen some cases because it's not a great tooth.
Yeah.
And they can't do extraction. They save it for the sake of avoiding an extraction. So we do elective root canal treatment just to bury it.
Okay.
Okay.
Hey, if that's the fair deal.
If let's say it's such a special situation, we might not need a root canal treatment. We might not even need to keep the tooth. Depends on the situation.
Yeah. I'm just saying. It's food for thought. Cool. We managed to do an hour and a half. So thank you so much for coming today and sharing your insights about dental implants and root canal treatment. I look forward to seeing you guys in the next episode. Thank you so much. See you then. Bye-bye.
Bye.